Hello medics, today we are going to see about post-menopausal bleeding. So first we start with the definition. In definition, you should know about what is that and where it's happening and when it's happening. So what is post-menopausal bleeding is any bleeding where happening from the genital tract after 1 year of menopause. So this is the definition of the post-menopausal bleeding. There are some basic criteria you should know about. First thing is menopause. A menopause is that a woman of more than 40 years of old with 1 year of amenorrhea is in menopause. Next, a woman at menopausal age with 6 months of amenorrhea, but now she has with bleeding per vagina, you should consider it as postmenopausal bleeding and you should treat accordingly. And a woman more than 52 years old continues to menstruate without a period of amenorrhea is also considered as an postmenopausal bleeding, and you should do investigations to rule out the malignancy and hyperplasia. Now, moving on to the causes of postmenopausal bleeding. According to the locations, we can divide the causes for our convenience. First, this whole region is known as vulva. This is the first region. Next involved is a vagina, which is here. Then cervix, then uterus, then fallopian tube causes and ovarian causes. Now, we see what are the pathological conditions in which we get postmenopausal bleeding. Any region, two important things are there. One is inflammation, which ends with itis, and then the second condition is the benign and malignant tumors. These lesions and these causes I have highlighted so you can remember easily. First, we start with vulva. As it is present in the outer region, it is most prone for trauma. So that is the first cause, followed by vulvitis and benign and malignant lesions. Then we moving on to vagina. First inflammation, so vaginitis, and benign and malignant tumors, followed by in vaginitis there are two types. One is post-radiation vaginitis. Due to any cancer, if the patient is exposed to radiation, we can suspect the post-radiation vaginitis, followed by senile vaginitis, which is more common in older age group, and due to foreign body there may also be bleeding like ring pessary, which we keep usually for prolapse of the uterus. Then cervix, first start with inflammation as I said, cervicitis, then cervical malignancies. Apart from this, we also have cervical polyps, erosions and ulcers. So after cervix, we have uterus. The uterus is lined by endometrium, right? So we get senile endometritis and tubercular endometritis. From this, we moving into benign and malignant conditions. Benign is the endometrial hyperplasia. Malignant is endometrial carcinoma and sarcoma. After that, we have mixed mesodermal tumors, followed by fallopian tube. In fallopian tube, inflammation is not that much prominent, so we go with directly malignancy. In ovary also, inflammation is not more prominent, so we go with benign tumors like Brenner's, granulosa and Thicka cell tumors. Then malignant condition like epithelial ovarian tumor. These are the causes based upon the location, and other causes are there which usually include blood dyscrasia, which means blood disorders. And then we have urinary tract disorders like urethral caruncle, which is growth from the urethra, and papilloma and carcinoma of bladder. This is in the anterior. In posterior aspect, we have bowel, so we have hemorrhoids, fissures and rectal cancers. These are mistaken for genital tract bleeding. So we should also rule out these conditions. And one important thing is that women in hormone replacement therapy are exposed to the estrogen more than progesterone. So women exposing to estrogen with unopposed progesterone have more risk of postmenopausal bleeding. Then we have tamoxifen, which usually used to treat breast carcinoma. So the adverse effect of this drug is endometrial hyperplasia. So this could be a reason. 20 to 30% of the postmenopausal bleeding is due to malignancy. It may be due to cervical, endometrial or ovarian tumor. Common benign causes are endometrial polyp, endometrial hyperplasia and dysfunctional uterine bleeding. Now we're moving into clinical features. Before clinical features, you should always ask the patient of history of use of estrogen and tamoxifen. And if the patient is having abdominal bleeding with foul smelling, then it most likely means malignancy. Then you should do a general examination including BP, BMI, why we should do BMI means in obese patient we have more risk of endometrial carcinoma. In abdominal palpation we can check whether there is any tumors present like that. And with the help of speculum and bimanual examination we can see any cervical lesions and all. Then we move into investigations. In investigations, in blood count and smear we can find any blood disorders which is known as blood dyscrasia and blood sugar level to rule out the diabetes, because in diabetes infection is more common than inflammations, and followed by cervical cytology and biopsy and sonosalpingography and ultrasound. In ultrasound, if the endometrial thickness is more than 4 millimeter, we should do a biopsy. And serum CA-125 levels to rule out malignancies. Malignancy is a life-threatening condition, so investigation is to rule out this malignancy. For this, we have three methods. One is dilation and curettage, and uterine cavity aspiration, and hysteroscopy with endometrial ablation. First, dilation and curettage. In this, we will get some scrapings of endometrium. With this, we can detect malignancy, the extent of spread, and staging of the tumor. Okay. Next, we have uterine cavity aspiration and hysteroscopy. This dilation and curettage requires general anesthesia and hospitalization. But uterine cavity aspiration do not need this general anesthesia or hospitalization. It is an OP procedure. Vibra aspirator, and another one is ISAC aspirator. This aspirator is used mainly to screen for patient on tamoxifen and hormone replacement therapy. They are more prone to get post-menopausal bleeding, and to rule out that we use this aspirator. And next one is to rule out the cancer. The best one is dilation and curettage, best method. Now, so nowadays we are using hysteroscopic visualization. In this, we will inspect the endometrium and take the biopsy accordingly and specific region. So this is considered as a gold standard method nowadays. Moving on to ultrasound. Ultrasound is used as an adjunct in all type of investigations, and CT and MRI is done mainly in the pre-op conditions to detect the extent of the tumor before going into the operation. Okay, next we go into Doppler. In this Doppler, we mainly check two things. One is diastolic blood flow, and next one is the resistant. If the diastolic blood flow is increased and decreased in resistant, it is mainly suggesting that malignancy condition. Okay, after ruling out the genital tract conditions, we do cystoscopy and proctoscopy to detect any bladder abnormalities and rectal abnormalities. Now we moving into the management. This management is usually based on to treat the cause, underlying cause. Okay, if no cause is found, we go with amount of bleeding. If there is only one bout of bleeding, we keep the patient under observation. Once the bleeding has stopped, in 80% of the cases, the bleeding will not occur again. But in 20% of the cases, the bleeding will not stop and continues. For those cases, we do laparotomy and hysterectomy. And while doing that, we may find a small tumor, ovarian tumor, which usually not detected by the investigations. Then, if there is more amount of bleeding, we do abdominal hysterectomy along with bilateral salpingo-oophorectomy, and we send the specimen to the histopathological examination. This is all about management. Now, the take-home message is that hysteroscopic visualization is the gold standard method, and to rule out the cancer, best method is that dilation and curettage. And for patients who are in tamoxifen and hormone replacement therapy, you should always use Vibra aspirator or ISAC aspirator and screen the patients on a periodic basis. Then there is one another thing. If you found out a benign cause, you should not stop the investigations there itself, because a benign cause and a malignant cause can be there together. So you should not stop the investigations once you found out the benign cause. So this is all about post-menopausal bleeding. Thank you guys. See you in next video.